So welcome everyone to the first session of our symposium for this year, which is putting nature-based health and therapy into practice. So we have 4 sessions this weekend, and at the end of the session, I will share with you the times for the remaining sessions and some other information. So this is the first time we've run a symposium like this for the Environmental Physiotherapy Association. And it came off the back of some discussions around, or from the festival last year. So it's great to 12 months on, be able to talk more about how to actually put this into practice. And we've got some fantastic speakers over the weekend. So in this first session, we have 4 speakers. So we'll have Oka, then Glenn. David Butler is unwell, so he's managed to put a presentation together for us, which is great. So we'll still have him involved, although he's not here in person, and then we'll finish with Nicole. So I'll hand over to Oka for the first presentation.
Thank you, Jess. And yes, again, what a pleasure and privilege to be together with, it's always just a joy to get together with the committee members, my colleagues from around the world, but especially very special to be gathered with the international group of people interested and actively engaging in environmental physiotherapy. So yeah, greetings, and I greet you from the Pacific, what we call Te Moananui, so the Great Ocean, the Great Pacific Ocean. And specifically today, I'll be just sharing a conversation around nature-based therapy from a perspective of Indigenous peoples in Te Moananui, so in the Pacific Ocean, and more specifically from the center of the Pacific Ocean, which is a group of islands known as Samoa. And Samoa holds lots of significance for the Pacific. It was the first nation to be made to become independent from colonial rule, and more ancestrally, it holds significance as the center of the Polynesian diaspora. So it's so forth known as Sa, the sacred, and Moa center. So the sacred center of that Polynesian diaspora. That's another presentation. But today I just want to share, just so you're aware, is that's sort of the perspective that I'll be coming from. To open up, I want to share a quote from Samoa, and it's a saying that comes from our maritime traditions, and it says, "E fofo e le ala mea." So the ala mea is a type of starfish, and fishermen used to learn that when you step on the starfish, it stings you. But the remedy for that sting is to flip the starfish onto its underside, and you rub that on the area where you were stung. And so the starfish would heal its own sting. And so that example has been translated and interpreted into that the solutions for issues facing our communities are often found within our own communities. And it's from that sort of perspective that I want to share the inherent connection that Indigenous peoples have with nature, and how this is evident in both in wellness and our well-being, but also in illness and so the recovery from illness, so all of life. And with that, I just want to share sort of 5 key touch points. Firstly, that Indigenous peoples share divinity with all of life. Secondly, that Indigenous peoples recognize and protect relational spaces. Thirdly, that Indigenous peoples preserve biodiversity as an outcome of that protection of relational space. Fourthly, I want to share some thoughts around the Indigenous therapist and what he or she looks like in my context. And then lastly, what the Indigenous clinic looks and feels like in my context. So firstly, Indigenous people share divinity with all of life. His Highness Atuia Tua Tupua Tamasese Ta Isi Efi, I feel like he captured it best in his renowned quote. So he was a former head of state and former prime minister of Samoa, but he shared this sort of position of ways of being and knowing for Samoan and Pacific peoples. He said, "I am not an individual. I share divinity with my ancestors, the land, the seas, and the skies. I am not an individual because I share a tofi, an inheritance, with my family, my village, and my nation. I belong to my family, and my family belong to me. I belong to my village, and my village belongs to me. I belong to my nation, and my nation belongs to me. This is the essence of my sense of belonging. So inherent in that quote, you could hear the spiritual connection between all of life. And carry that on further forward into the second point, which is Indigenous peoples recognize and protect the relational space. The term for the relational space in the Pacific is VA, or VA. And the imperative of the VA is that the VA is a relational space between two people or two things. And there is an imperative to protect and to nurture that relational space through the enactment and embodiment of cultural principles, such as service, such as love, such as reciprocity, hospitality. But this VA is not only between humans, but it is between all of life. And so Professor Albert Wendt, he says the VA is the space between. It's the betweenness, not empty space, not space that separates, but space that relates and holds separate entities and things together in the unity that is all. The space that is context, giving meaning to all things. And so what I'm hoping you're starting to hear is that there is a inherent in this way, these ways of being and knowing, is this somewhat of a resistance to ways of being and knowing that look to objectify us or to reduce us to an individual or reduce us to a human outside of our context and environmental spiritual connections. And the product of that, or the, one of the outcomes of such relational spiritual connections with other humans and non-human life, is that Indigenous peoples preserve 80% of the world's biodiversity. And this is critical, particularly with the existential challenges that we face with regards to climate. And so there's much that we can learn from our Indigenous peoples right across the world. So if we move towards the Indigenous therapists, for many of us as physiotherapists, there are also lessons that we can learn from the Indigenous therapists. From my doctoral research, which explored how Samoan cultural knowledge could enhance physiotherapy, when I asked participants, well, what does culturally dignifying physiotherapy look like? They all pointed to the traditional healers, and they said, these people are culturally safe therapists because they are respectful in gesture, in language, in hospitality, in posture. They are always available, so we can access them any time of day. We don't have to pay them in cash, but we can give them gifts in kind. They always utilize therapeutic touch, and they do that while they're discussing and so communicating their diagnostic process. And the importance of this is twofold. Firstly, that it helps educate and inform our patients and their families, but it also soothes the sense of vulnerability that people arrive with due to their illness or their condition, but also the sense of not knowing, particularly for many of our communities, not knowing what is happening with their bodies. And so this is really, it stands as a lesson for us and something to be keenly aware of as physiotherapists, because our profession has moved so strongly towards exercise-based interventions and also medical imaging as part of the diagnostic process, that there is something still inherently therapeutic about touch for our Indigenous communities. And then lastly, I often have an image here shared of of oils and balms that are derived from our surrounding natural environment. And so the use of these, my participants mentioned, it speaks to their ecological sense of well-being. And then lastly, to the Indigenous clinic, I want to share a quote from a groundbreaking study by Forsyth in the 80s, who traveled to Samoa to try and classify what the therapists were doing and how similar they were to Western clinicians. And she describes the traditional Samoan clinic like this. Daylight came into the room through the soft curtains and filled the room with light. Sitting inside, one could see the brilliant shades of green from the extensive foliage, lit by the bright sun that surrounded the house. On the floor of the clinic was linoleum that ran wall to wall. On top of the linoleum were 3 large mats, woven mats, upon which to sit. Or if one was inclined, there were a number of large wooden chairs with pillows for cushions upon which to sit. The room was large, clean, and attractive. There was nothing hospital about it. There were no clinic nuances, such as efficient secretaries and assistants answering phones and keeping appointments straight. Yet the Taulasea's whale, or house, seemed like a clinic. It was always busy. It was always full of people. There were countless visits during the course of study in Samoa, and it was always busy with activity. Many people took taxis to the clinic on their way to and from work. Some came during their lunch hours. It was discovered that some even had appointments, which was unusual, but they had told her a time and date that they would come back, or she had asked him to return for a checkup of some kind. But most had no appointment and were there quietly waiting their turn. The Taulasea, or traditional healer, saw people not necessarily in order of their appearance, but in order of their need. If all were able to wait, she took them as they came, but emergency cases or someone in great pain would be seen first. The thing that was noticed was that no one was turned back because the Taulasea was booked or too busy. The Taulasea attended to everyone before she called it a day, whether there were 5 persons or 50. End quote. And that's from Forsyth's 1983 study. And so in closing, I just want you to get an appreciation of how the traditional clinics looked and felt like they were open. There was sunlight streaming through. They were surrounded by foliage. And they were busy but unhurried. There was a sense of patience and waiting and healing in that process. So in closing, I want to close with a final quote from Samoa, and it says this: "Ea fua mai maunga, whamanuianga ale nuu," which translates to blessings for the village flow from the mountains. And this imagery holds a river that stems from of spring water from the mountains, and it benefits the villagers who reside on the flats. And so that's my it's often used as a picture for those in decision-making positions of influence or leadership within families and communities, that your decisions and your important work has downstream impacts, and hopefully impacts that benefit our communities downstream. And so I just want to wish you the best with your important work and your decision making, and hope that it benefits those who seek your guidance and your leadership going forward. So thank you for the opportunity. Enjoy the rest of this important symposium.
Thank you, Oka. That was fantastic. So it's fantastic to have a different perspective from what a lot of us have been exposed to previously. So thank you. And I'm sure there'll be more questions and things for you later in the discussion. So next we'll pass over to Glenn. So Glenn, if you want to share your slides.
Okay. Hold on 1 second.
No worries.
All right, can you see those?
Not yet.
Okay, what do you need for me to do to share my slides? Share, there we go. I think I'll press that button. There's one. All right, let's try that.
That looks good.
Okay, All good? Great, thank you. Hello everyone, my name is Glenn Ruscoe. I'm the chairman of the International Physiotherapy History Association. I'm located in Perth, Western Australia, and the traditional owners of the land here are the Whadjuk Noongar people, and I'd like to pay my respects to their elders past, present and emerging. Today, I'd like to share with you some of the history of physiotherapy, explaining how its roots lie in nature-based health. It's a wild story, a wild mix of rebellion, greed, patriarchy, war, suffrage, and epidemics that have shaped physiotherapy to create what we've become today. Ancient history is replete with the use of physical therapies by cultures all around the world, and is perhaps best summarised by a quote from the Canadian Radiological Society in 1931 that said, in daily service, since the dawn of light on the earth, physical agents have been active in promoting health, happiness, and well-being. And whilst ancient practitioners undoubtedly would have overlapped their application of the individual physical therapies, it was the coalescing of their delivery beginning in the 1850s that created a unique and autonomous practice of health provision. So our story begins in Germany, where Bavarian physician Lorenz Gleich wrote extensively of physiotherapy. He did not invent the word. That had occurred 20 years earlier with fellow German physician Friedrich Siebenaar from Dresden. But Gleich significantly progressed the idea, and among his many writings, he described physiotherapy by inclusion, its elements consisting of food, water, movement, air, light, heat, electricity, magnetism, etc. Later inclusions, albeit temporary, were psychology and radiology, highlighting for at least a short period that physiotherapy was equally defined by exclusion, being everything that was not surgery or pharmacotherapy. And it is by being everything that was not surgery and pharmacotherapy, the two components that defined medicine at the time, that was the impetus for the foundation of physiotherapy today. But Gleich's mid-18th century writings were part of a broader medical protest movement, rebelling against the dubious and dangerous practices of bloodletting, purging, and the prescription of dangerous drugs being the prime treatments of allopathic medicine at the time. The most successful physical therapy was water, and hydropathy, as it was known, included the ingestion of and the bathing in cold water. Additional natural treatments like dietetics, massage, and exercise were later added to the services of the hydropathic facilities that sprung up throughout Europe and North America. The medical profession responded with disinterest, but that soon changed as the extraordinary results brought forth by the water cures and other physical therapies began to challenge the status and the income of the medical practitioners. By way of example, a medical commission of inquiry was launched in Germany in 1895, and the chairman, Professor Kussmaul, reported, "It cannot be denied that the faith in prescriptions is waning among educated people, and that confidence in dietetic remedial methods and in the curative power of water is in the ascendant. Of hydropathy, the young physician knows almost nothing when he leaves university. Unfortunately, he sooner or later may encounter discomfiture when an uneducated water doctor steps in and cures the patient after he has failed." However, by the end of the 19th century, despite its clinical successes, naturopathic medicine could not match the allopaths' hold on science, higher education, and legislation, and the naturopathic proponents were relegated to the fringes of the medical field. Nevertheless, their results had stimulated sections of the medical profession to become interested in mobilizing the patient's own healing powers through the use of physical therapies. On the other side of the Atlantic, with a similar refrain, Canadian physician Edward Plater published a paper in 1894 titled "Physiotherapy First, nature's medicaments before drug remedies, particularly relating to hydropathy. Plater lamented medicine's prioritisation of pharmaceuticals and explored the physical therapies of pure air and sunlight, diet, rest, psychology, electricity, massage, movement therapy, and water. Whilst erroneously claiming to have invented the word physiotherapy, it was at least the first publication of the word in English. Toward the end of the 19th century, medical societies and institutions formed around the enthusiastic use of the physical therapies by physicians, particularly in France and Belgium. This is a quote by Adelante in 1903. Thanks to the initiative of a few doctors who had the courage to break away from old routines, France has finally firmly entered the path of the natural treatments, which involve therapeutics through hygiene, physical agents and methods, excluding chemical medications and harmful poisons. It has been given the name physiotherapy. Courses in physiotherapy were offered to physicians. For example, in 1899, French neurologist Professor Louis Landauzy advertised a course that included a session on physiotherapy, covering the therapeutic use of air, water, climates, electricity, light, heat, cold, and movement. The new medical societies began to publish journals, newspapers, annals, and gazettes. For example, the Journal de Physiothérapie was first published in January 1903. Several international congresses were organised with the ambition of establishing physiotherapy as a medical discipline equivalent to surgery and pharmacy, a third branch of medicine. The first of these congresses took place in Liège, Belgium in 1905 and was attended by more than 100 physicians from 18 nations. The promise of physiotherapy as a new medical specialty gained such attention that some enthusiastic physicians were claiming it to be a turning point in the history of medicine. And the title physiotherapist was adopted by physicians in at least France, the United States, and Russia, which in part explains why our colleagues in those nations use alternative terms. Discussed at the first International Congress of Physiotherapy in Belgium and the second in Rome and the third in Paris were concerns that physiotherapy is largely left to laymen for exploitation. A quote from Meynell in 1905, "We see people turning to bone setters and charlatans whose numbers seem to increase as the field of physiotherapy expands." Indeed, many charlatans did exist, especially for electrotherapy, where both practitioners and manufacturers made broad and fanciful claims of efficacy. Their actions tainted all of the physical therapies and, more broadly, physiotherapy as a practice, thereby subverting its wholesale adoption by the medical profession and casting suspicion on all practitioners. The bone setters and charlatans referenced any and all independent non-physician practitioners, including the masseuses and remedial gymnasts, who were the progenitors of physiotherapy today. Awkwardly for the physicians, however, some of the non-physician practitioners had driven the very innovations in the field. For example, Swede Per Henrik Ling and his system of gymnastics, and Dutch remedial gymnast and later physician Johan Metzger and his system of massage. With livelihoods at stake, competition amongst physicians and non-physicians was strong. Unable to criticise the science-based practices of the massage and remedial gymnasts that they themselves used, the physiotherapy physicians sought primacy by directing doubt on the ability of the lay practitioners. Remedial gymnastics and massage in themselves were thus not quackery, only so when practiced by non-physicians. The physicians' bullying peaked with the London massage scandals of 1894, where the British Medical Journal led a campaign of moral outrage that sullied the practice of massage by turning it into a euphemism for prostitution, a strategy also used in the United States and France. As we all know, the physicians ultimately gained sovereignty over the health sector, and in response to fight for legitimacy and market share, the massage and gymnastic practitioners began to unite in service and in professional associations. Whereas the predominantly masculine osteopaths and chiropractors chose to challenge the power of the medical profession, The predominantly feminine massage and gymnastic lay practitioners saw greater massage in aligning themselves with medicine, albeit in a necessarily subjugated role, taking direction from the physicians. The First World War began in 1914, and the grouping in large hospitals of innumerable injured service personnel who had to be returned to functional ability in the shortest possible time provided an extraordinary opportunity for the physiotherapy physicians to test the physical therapies on an industrial scale and thereby finally demonstrate their value to governments. A significant step forward was realised in the French centres of physiotherapy, where they were tailoring combinations of the physical therapies to each individual soldier's needs. Whereas previously, the protagonist of each physical therapy was siloed, the results of this highly innovative and exceedingly effective tailoring strategy was reported enthusiastically in the medical literature around the world. The volume of work, however, plus the relative laboriousness of applying the physical therapies exceeded the capacities of the physicians and stimulated the need for a labour force to assist in the rehabilitation process. Having previously accepted medical hegemony, the massage practitioners and remedial gymnasts were accepted to help as aides or technicians. Due to manpower shortages, women were primarily trained to take on this role, and it was an attractive opportunity for upper and middle class women seeking to enter the workforce, work being a privilege previously denied them. And so the women themselves were highly intelligent and capable. Soon, tailoring the treatments using their own initiative, the actual practice of physiotherapy moved from the physicians to their assistants. Combined with subsequent polio epidemics, increased industrial accidents in the Second World War, the support of rehabilitation by the massage practitioners and remedial gymnasts became increasingly successful. At the same time, physicians were being seduced by the siren call of new, more powerful pharmaceuticals and advanced surgical techniques. And many of the originally enthusiastic physiotherapy physicians painfully morphed towards the specialties of radiology, rheumatology, and orthopaedic surgery. As the medical profession's interest and grip on the provision of physiotherapy softened, and the massage and remedial gymnasts grew more confident in their broadening skill set, by now also including electrotherapy, hydrotherapy, and light, the massage and remedial gymnasts assumed primacy in the field and progressively adopted the title physiotherapy to better describe their vocation. If you'd like to learn more about physiotherapy history, I'd invite you to visit our website at www.history.physio, and we have a particularly good article that we just released called The History of the Word Physiotherapy. And if I could finish by acknowledging the assistance of Sandra Schiller from Germany, Robert Jones from the UK, Cameron McDonald from the USA, and Ryan McGrath from Australia. Thank you.
Thanks, Glenn. So it's great to hear more about the history of our profession, which I think a lot of us perhaps don't know to the extent that you've shared with us today. So it's great to see those origins. So next we have a video presentation from David Butler. So I'll get Philip to share that.
Hello everybody, many thanks for the invitation. I'm so delighted to present for such an important group, and I'm sorry I'm not here in the flesh. I've been providing chronic pain talks to gardening clubs and professionals via a group called Pain Revolution. This is in rural Australia, where chronic pain prevalence is higher than in urban areas. Let me share some of the curriculum fundamentals. First, I take a very broad view of gardening, from veggies and flowers to cultivating 1,000 acres. But also the use of pot plants, or even at looking or thinking of a garden if incapacitated. I push the use of public gardens and spaces, but with new knowledge. I use the term gardening broadly. Of course, you could also use the word nature. Secondly, pain is a focus, but the material is relevant for other body-brain environment constructions, such as anxiety and depression. I talk science, always talk science, and make it relevant. Many rural people distrust science, For example, I might say scientists will show us that 15 minutes of the exact same exercise outside works far better for memory, concentration, and blood pressure than inside. And even one pot plant in a computer room will drop blood pressure. And finally, I integrate first-person derived data showing the key things, the key information that patients who have recovered from modern chronic pain programs found useful. And they are that pain is a protective feeling and we frequently overprotect. And you can probably do more in the garden in nature than you think you can. Secondly, that pain and injury do not relate. Thirdly, critically, that many things construct the chronic pain experience. Therefore, many things can help. Fourthly, change is always on the cards. And finally, active, not passive therapies are better. I provide 5 short stories. They are your garden, your teacher, your garden, your lover, your garden, your health coach, your garden, your protector, and you are your garden. This always makes it more exciting, but the 5 stories allows me to hit those key points at different contexts. So let me give you some content examples in each of the stories. First, your garden, your teacher. So we talk here about gardens teaching us about how brains work, essentially distributed processing, and how there are patterns of activity right across the brain no matter what you do. How it works like an orchestra, and the old story that you only use 10% is bullshit. And we talk about how in pain there's a widespread pattern of activity because persistent pain is never due to one thing. It's a combination of what's going in your body and brain and world. We say everything matters. Things you hear, see, smell, taste, touch, thoughts, things you do or don't do, people you hang out with, places you go to, old memories, stuff going on in your body. And there's space in your brain for all of this. But gardeners, I say, you already know this. You know that everything matters. In a garden, in nature, soil, water, amount, quality of the climate, time of planting, pruning, guarding, here in Australia, your possum numbers. So I say to my gardeners, you are already brain scientists. Gardens, nature makes us aware of the fundamental aspects of life. And if so many things create pain, it also means that there are so many things you can do for it. And there's always somewhere to start, no matter how small. The rest of this first story is all about change. We talk neuroplasticity, how we can change just as our gardens do. And I remind them that successful gardeners are already great problem solvers. And I ask them then, can you start to apply this to your pain, anxiety, or stress state? Story 2, your garden, your lover. Here I talk about the love drug, oxytocin, and how we all make some, even us males. And how natural oxytocin is good stuff. It makes you happier, less stressed, eases pain and anxiety, helps heal injuries, and how people with persistent pain have less oxytocin floating around. So I ask them to seek a dose. You'll get some from a cuddle. Patting a dog or cat, you'll both get an oxytocin blast. Being welcomed and sharing something. And how, importantly, your garden and gardening can give you a dose. Think that feel-good welcome when you walk into a garden or botanical gardens or marvel at an amazing plant. The bonding, that's oxytocin. Watching a plant grow, watching it support other animals, sharing produce, that's oxytocin. People get married in gardens, not traffic intersections. So it's got a lot to do with pain. Seek a daily dose. For example, if you're in hospital or away for a while, take some photos of your garden. If somebody miserable turns up, have a cup of tea outside. Imagine a cuddle in the garden. I gave this talk recently on Kangaroo Island in South Australia, where gardens were devastated by fire. And right now the gardeners were getting excited. They thought there was an erotic bit to my story coming up. Well, but also in this story about your garden, your lover, I spend time on getting them to find their safe places, knowing plants, talking to their plants. If you've got a pot plant, name it, repot it. We talk harvest highs, the smell of rain and how it can liberate serotonin. And I remind my gardeners that the garden will also offer hard love, the release from stress, digging out a tree, serious pruning, killing bugs. If angry and upset, you go out in the garden, reflect on that. So in summary, story 2, nourish your garden, you nourish yourself. It's free, no prescription needed, totally natural and available 24/7. The garden, nature, is just waiting for you. Story 3, your garden, your health coach. Here I cover lots of things like aging myths, such as pain is inevitable with aging, and that age by itself is not a reason to stop gardening. How we don't wear out, we adapt. We talk about the psychological and eating benefits for children. We talk x-rays, for example, that our backs with flat discs, more bones, stiff bits, little bits poking out, actually usually become stable platforms. You're a bit stiff, but that's quite good for gardening. And how we all need this pain system, rejoice in it to protect and help us heal. But how sometimes we overprotect when we weigh what's going on in the world and we make too much pain. Here, we spend quite a bit of interactive time with my gardeners on the Twin Peaks model from the book Explain Pain. Briefly, on the left, before problems. When younger or pre-injury, you could have climbed a mountain, garden non-stop. Let's use the mountain. As you climb the mountain, it gets a bit harder and harder. Notice the protect by pain line. Things start to ache. But notice you haven't challenged your tissue tolerance, i.e. damaged things. You can get to the top, but it's a bit risky. The key thing when you look at is that there's a buffer space to protect you. Great system. There is no buffer if you do things too fast, of course, like fall off your horse. But check out mountain 2 on the right, after problems. Or this will be happening in most older people. Notice how the tissue tolerance line's a bit lower than before. With all of our injuries, given time and a bit of medical help, things will heal. Best to think that your muscles, ligaments, etc. are a bit unfit, maybe stiff, not quite what they were when you were 40. Still bloody sparky though for everything you need. But look at the protect by pain line now. See, it's lower. Pain coming in sooner than mountain 1 to protect you. Check out that new wide buffer. Remember, just a few minutes ago, I told you that pain's not only generated by dodgy body parts, but by all the other things going on in the world. Everything matters. This buffer zone is usually wider in older people than younger people, as we try and protect, and nearly always wider in people with chronic pain because so many things matter. And if you look at it, you can see that you should be able to do something like gardening, go up the mountain, garden, have some pain, but know that while you're sore, you are still safe because you're nowhere near damaging tissues. So being scared of your x-ray, just believing pain is forever, believing you're too old, fear of the garden, scared of the Russians, all can drop pain and pain will start sooner. Key message from story 3? Sure, get checked out. Some pain's okay, but it's difficult to hurt body parts unless you go really crazy. And when you know pain's not a threatening thing, that it's a measure of your protection level, you can do more and it can lessen. We say no pain and you'll no gain. Get out in the garden and try that thinking out. And finally, to finish this third point, remember it was supposedly Audrey Hepburn, keen gardener, someone who always shared her vegetables with neighbours, who said to plant a garden is to believe in tomorrow. Don't stop. Story 4, your garden, your protector. 2 parts to this story. The first one is on old bacteria, our friends in the soil and vegetables, in the soil and vegetation, links to the healthy biome. Other speakers will touch on this. But we spend time with our gardeners on what I call the nature protectometer. Ideally, our immune system should be in balance. Too much immune activity, no good, can lead to arthritis, maybe cancer, but not enough. Slow healing can put you right out of whack. The best way to look at it is to have a healthy balance of things that are dangerous for you and things that are safe for you. A dim means danger in me. A sim means safety in me. In your garden, in your public park, your hiking trail, even your pot plant, you have sims. So with my group, we go sim hunting. Here's a rather large slide, but let's take a look at it. In the middle, we've got categories. I'll give you examples of some of these. First category, things you hear, see, smell, taste, and touch. Well, the dim could be just looking at an X-ray, but the sim could be watching bees, worms, butterflies, smelling rain, touching lavender, taste the first fruit, finding shades of green. And any time my gardener gives me an example, I'll give them a scientific reason for that. For example, it could be distraction. It could be making new pathways in the brain. Things you do. Look, a dim could be limp, never bending. But the sim could be finding your activity sweet zone, the level that's just right for you. Planting something exotic, repotting a pot plant, and reflecting, just having gardening achievement emotions. When you get out of the garden, rather than just sitting there and having a gin and tonic, take 20 seconds or so to reflect what you've done. And that will create this beautiful cascade of chemistry in your brain. So next time you're out there, it'll even be easy. Things you say. The dim could be grunt, saying, I'm stuffed. But the sim could be saying, I can move and improve, bend and mend, motion is lotion, having happy grunts in the garden. I love singing Octopus's Garden, if you want. Things you think and believe. Look at the dim. Could be bad things always happen to be. But the sim could be in the garden thinking, I'm sure and safe. I can adapt and change. And as one gardener said to me recently, hey, my garden's a gym, a pharmacy, a club and a supermarket. Places you go. Look, the sim could be other gardens, lavender farms, window outlooks to a garden, your garden's safe place, botanic gardens. People in your life. Look at the sim, other gardeners, gardening shows, sharing fruit and veggies, and things going on in your body, the sim in the garden, just knowing you're doing brain-body exercise, knowing you can grow and eat anti-inflammatory foods, finding good bacteria. The garden's full of sims. The aim is to demolish dims and seek out the sims. And my final short story is You Are Your Garden. This final session is about embodiment. I ask people to be proud of where they live and see the beauty and essential nature relationship. Michael Jackson, for all his shortcomings, had it right when he sang, We are the world. Embodiment can help make sense of things. So gardeners know exactly what I mean when I say you tune into your garden. You become part of the whole thing. You can become part of the whole world, bigger than your garden. How you hurt when your garden is ill. How when you're away, you're worried about your garden. It's the first thing you look at when you come home. It's a part of you. So gardening's not external homework. It's a relationship with yourself. And you realize that you and nature need each other. So one key takeaway from that, the necessary life changes for successful pain treatment can be hard, but changing the surrounds of which you are a part of, i.e. your garden nature, can nudge you to the changes you need. Hey listeners, maybe some of the answers to chronic pain problems were looking at us in the face. We just didn't realize the power of connecting, using, understanding, and contributing to nature. Many thanks.
So I think we're very fortunate to have had David share that video with us. So just providing, I guess, a different perspective and very much so how we can explain this to our patients and clients in terms of why all of this matters. So that's great. So finally, we have Nicole. If you want to share your screen.
Are you able to see the slides? Okay. Perfect. So my name is Nicole Struthers. I am a PhD candidate and first-year student in the Master of Physical Therapy program at Western University in Canada. And today I will be talking about the use of nature-based interventions when you're thinking about physical health conditions. So to start off, what is a nature-based intervention? So these are your activities, strategies, or programs taking place in natural settings with the aim of improving health, social, economic, and environmental outcomes. So some targeted benefits can include improved physical health, emotional well-being, social connection and cohesion, as well as sustainable health cost savings. Natural settings can include anything that could be classified as green space, so local parks, trails, forests, conservation areas, gardens, greenhouses, and agricultural spaces are just a few examples. And it can also include blue spaces such as rivers, lakes, and oceans. So the benefits derived from nature-based interventions stem from ecosystem services, and these are the benefits provided by healthy, functioning ecosystems that contribute to making human life possible and worth living. They include food and clean water, as well as non-material benefits to human health and well-being, such as reduced pain and improved social integration. So nature prescriptions are written or verbal recommendations to spend a minimum of 2 hours a week in nature spaces to receive the benefits of ecosystem services. These prescriptions can include goal setting, educational material, and referrals to local nature spaces. It can also include specific outdoor activities such as green exercise, which is physical activity that is intentionally conducted in natural settings, active transportation, and everyday activities that could be classified as physical activity, including playing with your grandkids at a park, or even taking your dog for a walk. Thalassotherapy is the use of the marine environment for therapeutic benefits under medical supervision and with a preventative or curative purpose. It has been used in the prevention and management of chronic diseases, including stroke, fibromyalgia, psoriasis, and mental health conditions. Thalassotherapy leverages the benefits provided by exposure to seawater, the marine climate, and the sun. Components of the marine climate and environment include warm air or sea breeze, seaweed, mud, sand, plankton, and these are thought to contribute to various health benefits that can be derived from this intervention. So activities could include simply relaxing in seawater, but it could also include like physical activity and exercise to further the host of benefits that could be obtained. So forest therapies have risen in popularity as valuable and accessible nature-based interventions. Shinrin-yoku, also known as forest bathing, originated in Japan in the 1980s. And forest bathing can include meditation, physical activities such as hiking and structured outdoor exercise programs, as well as leisure activities, which could include bird watching or tree identification. To receive the benefits of forest environments, Shinrin-yoku has participants let nature into their bodies through seeing, hearing, touching, smelling, and tasting their surroundings. And forest bathing has been shown to provide numerous health benefits. So this can include improved hemodynamic, neuroendocrine, metabolic, and inflammatory markers, enhanced emotional state and attitude, as well as alleviation of symptoms of mental health conditions, which have been reported in the literature. Green space exposure has numerous benefits, as shown on the slide, and the abundance fosters the potential of nature-based interventions to be valuable in healthcare, especially in the prevention and management of chronic health conditions. Previous reviews on the health benefits of nature report the effect of nature exposure and nature-based interventions on a variety of health outcomes. However, the results of these syntheses are not reported with respect to the health conditions of the populations included within the review. So this gap in the literature led me to conduct a systematic review to understand the effect of nature on whom, with what conditions, and on what outcomes to maximize the use of nature-based interventions in healthcare practice. So our literature review identified 20,000 records and ended up including 26 records, with 15 being included in meta-analysis. The included studies were published between 2008 and 2023, with the majority within the last decade. China and Spain were the two dominant countries where studies took place, and most studies had a population of older adults, with only 2 having a mean age under 20 years. So sample sizes also varied, with the smallest being 15 participants and the largest being 407. The most frequently reported nature-based interventions were forest-based, such as forest bathing and walking, and non-forest-based outdoor walking. 16 different physical health conditions were studied, including hypertension, type 2 diabetes, and low back pain. These conditions were then grouped into cardiovascular, central nervous system, endocrine, musculoskeletal, and respiratory conditions. In total, 73 physical health outcomes and 8 biomarkers were reported. The findings of our systematic review suggest that nature-based interventions have a beneficial effect on a variety of physical health outcomes of different physical health conditions. We conducted 17 meta-analyses, but these tended to have high levels of heterogeneity and were comprised of 2 to 3 studies each. 4 meta-analyses had confidence intervals that did not cross the null, And these were diastolic blood pressure and heart rate for cardiovascular conditions, fatigue for central nervous system conditions, and body fat percentage for endocrine conditions. And regarding the outcomes that weren't included in the pooled results, a wide variety of physical health outcomes and biomarkers were reported with both between groups and within groups statistical significance. So for key findings, diastolic blood pressure and heart rate were reduced for people with cardiovascular conditions in the nature-based intervention groups. And both of these outcomes influence the risk of cardiovascular disease and adverse events. So this finding is valuable in the prevention and management of different conditions, including hypertension, coronary heart disease, and stroke. Nature-based interventions also reduced body fat percentage in populations who were overweight or obese. And the reduction of body fat percentage is notable as both classifications of excess body fat increase the risk of developing other physical health conditions, including type 2 diabetes, hypertension, and osteoarthritis. A weight reduction of 5% or greater annually is a target for obesity management efforts. So nature-based interventions could foster achieving and sustaining this target through incorporation into weight management and excess body mass reduction efforts. And lastly, in people with central nervous system conditions, fatigue was reduced in the groups assigned to nature-based interventions. So fatigue is a disabling and multifaceted symptom that is prevalent and persistent. So nature-based interventions may be a valuable component of multimodal management of fatigue. So kind of the take home from our review is that nature-based interventions are promising therapies that clinicians can integrate into practice to reap the beneficial effects on a variety of health outcomes and commonly experienced symptoms of chronic conditions that may be hard to manage. It may also have a multiplying effect for patients with comorbid conditions such as overweight or obesity, hypertension, and osteoarthritis. Future studies should focus on clinical populations to further the evidence base on the use of nature-based interventions in managing chronic health conditions, conduct high-quality, rigorous studies, use commonly reported outcome measures for different health conditions, such as common test batteries to improve comparability between studies, and investigate the effects of nature-based interventions adjunct to pharmacologic treatment and report any fluctuations in medication use. So with the growing body of evidence supporting the benefits of green space exposure in connection with nature, physical therapy can start to consider how the outdoors can be brought in, such as in a rehabilitation plan and how clinics are set up. Although patients are likely to come see you for one problem that they're experiencing, that doesn't mean that the use of nature-based interventions are restricted to that presenting complaint. So for example, the chief complaint of this patient is low back pain. However, nature-based interventions can help manage the symptoms of low back pain through increased physical activity and the benefits of green space exposure. Together, these can improve function as well as help with pain management. So nature-based interventions can also aid in the self-management of comorbidities that a patient may have that you find out through a patient interview or their chart. And these could be high blood pressure, fatigue, or mental health challenges. So the benefits of physical activity and exercise prescribed by physical therapists can compound these benefits further. And lastly, when creatively employed, nature-based interventions can address the psychosocial impact of a patient's impairments or restrictions. So this example patient could be educated on strengthening exercises and modality use while in a physical therapy session, but they can also be recommended to re-engage with their community garden to reduce the potential for reductions in social connection and quality of life. So bringing the environment into physical therapy practice not only benefits clients, but can also benefit the planet. And on that note, the inclusion of nature-based interventions in healthcare can lead to numerous benefits beyond those for human health that were previously outlined. Ecological restoration is a process of assisting the recovery of an ecosystem. The healthcare system can support this process through adopting environmental considerations within practices, services, and products. As well, clinicians can also become advocates for public health and policy changes that support the health of their patients and the environment. Clinicians can also support and promote active transport in natural spaces and conservation activities within a nature-based intervention to allow for planetary health co-benefits. The health benefits derived from green space exposure, including pain reduction and improved social integration, not only impact the condition that clinicians are assisting the management of, they can also positively impact various comorbid chronic conditions and overall physical and mental health. By increasing the amount of time and connectedness to natural environments, nature-based interventions can facilitate the uptake of pro-environmental behaviors by patients and clinicians. These behaviors can include advocating for conservation, restoration, and sustainability. Through conservation and ecological restoration, ecosystem services can be maintained to allow for planetary health benefits through the uptake of nature-based interventions in healthcare. So planetary health is defined as the achievement of the highest attainable standard of health, well-being, and equity worldwide through judicious attention to the human systems, or the human systems that shape the future of humanity and Earth's natural systems that define the safe environmental limits within which humanity can flourish. So in conclusion, the use of nature-based interventions can help the emphasis of healthcare lean towards being more promotive and sensitive of environmental determinants of health and are intertwined with the health of the planet, while also providing a host of physical health benefits. And I have linked the systematic review on the slide if you would like to take a look at it. Thank you.
Thanks, Nicole. So it's great to have 4 very different presentations coming from very different perspectives. So hopefully everyone's gained some different knowledge and different ways of thinking from the sessions today. So we've got a bit of time now for questions and any discussions that people want to have. So does anyone have anything they would like to ask our speakers?
And I just want to highlight that we also invite speakers to ask questions to each other, of course. But yeah, please use your hand signs and the likes and yeah. Sean.
Thank you, Jess. Thank you, Philip. My question was going to be for Nicole, but then I saw Oka with a family member in the screen. So hello, Oka's family member. You all look adorable. And to go to my question for Nicole. Nicole, thank you so much for your work. I was actually able to incorporate this into my class for scholarly practice at l'Université de Sherbrooke in Quebec. And it was really exciting to be able to look at those interventions with our students in order to think differently about what we do in physiotherapy. And it blew their mind when they found out that the author of that paper was maybe only a few years older than they were. So that was really cool. In the process of talking about your work, it did raise the question about your distinction between physical health and mental health. And I can understand as an author that that would have been a conscious decision because you were still able to cover a lot of ground in the systematic review. But I wanted to know your opinion on that. Well, whether you think that the distinction between those two of physical and mental health might have some drawbacks. And if you had the opportunity to do a second wave or to go back and do it again, if you would approach that differently.
Yeah, so there definitely are drawbacks. When I started the review, I hadn't yet started the physical therapy program, so I didn't have as much of a complex background on how something like pain could be strongly driven by a social or emotional state and not necessarily something that's a physical driver. So in retrospect, I probably would have considered things like cognitive outcomes a bit more, or emotional, but I kind of made that distinction because there is a large body of literature on the mental health benefits. Whereas this was something where I noticed that papers were saying that it would reduce blood pressure, but they weren't saying for who. And then if you wanted to recommend to a patient with hypertension, you probably want to know that it actually is going to help that clinical population. I would love to go back and update it in the future and be able to kind of expand on the cognitive side of things, but I think the mental health aspect should be left to someone who has a bit more knowledge and a bit more sensitivity to that topic, whereas I do have more of the biomedical perspective from my own work.
Thank you. And yeah, I think it's amazing that you went through over 20,000 studies to whittle it down to the relevant ones. So I think that in itself is huge effort. So Philip.
Yeah, yeah, thank you all for the presentations. What do I do to lower my hand? There it is. I kind of have a question to all presenters, but with David not being here, the question sort of goes to the remaining presenters, which include Oka, Glenn, and you, Nicole. I think between actually the 4 of you, I've heard loads of different things mentioned as nature-based health and therapies, right? Like, so I'm kind of questioning or asking about the definition of whatever this might be. And it's probably a fitting question for a first session of this symposium, and we'll have 3 more sessions that will probably continue expanding on that. But I've heard the 4 of you talk of a whole bunch of different things as nature-based health and therapy. And it probably something is that it looks like that definition needs to be about a page or several pages long. So if I just kind of recount some of the things that I've heard, like in Oka's presentation, I think, the clinic kind of really stuck with me. It's, how it's this kind of clinic environment and, the sunlight going through, the foliage being around and all of that, but also in some ways this sense of, the connectedness with nature also being an element of nature-based health and therapies. And then Glenn continued with the air, water, and all the kind of natural agents, as something that sort of seems to relate to nature-based health and therapies. And of course, David was there with his gardening, but actually David also touched on thinking about plants and outdoor spaces potentially as nature-based health and therapy. And then of course Nicole with the sort of like outdoor physical activity in natural environments. That's a huge field. I wonder, I mean, yeah, I don't know, maybe I've just kind of recapped what I heard in your presentations. I don't know whether that works as a question. But I just have your thoughts on kind of like this question of the definition of nature-based health and therapy. I don't know, who of you 3 wants to jump in on that one? I would love to hear your thoughts, all of you, but any.
I don't know if I was jump in here. Yeah, well put, Philip, I think. And yeah, thank you to my colleagues for your presentations. I've really enjoyed it. I think what comes to mind with that question is, I guess, in the first instance for Indigenous peoples, therapy outside of nature is foreign, is unnatural. So nature-based therapy is natural. And I guess that's what I was trying to convey with the images of what therapy looked like and the sense of connection, the deep connection to land that, one of my participants made a quote that wellness is a collective process and illness is a collective process too. Whereas in our current contemporary Western health systems, we go from this collective well-being and then we kind of become this individual patient with a serial number that goes through a individual Western process, detached from the things that give them meaning and belonging and well-being, as David kind of touched on. So I think, for me, your question poses whole paradigm differences. And I loved, Glenn, your presentation to walk us through the history. And what was evident to me was not only what occurred, but also that the unintended consequences of those deliberate decisions as well, not including Indigenous methods, methodologies, theories into shaping physiotherapy's movement forwards, and what that did in terms of kind of fidelity to a biomedical worldview, which is kind of downstream, fast forward a few hundred years, and now we're at Nicole's study, whereas we're kind of trying to unpack that, but still attach it to the biomedical paradigm that we're steeped in, but recognizing that there's this whole other worldview that Sean, touched on around the inseparability of health systems and, mental health, well-being, which, which is held really well in Indigenous paradigms of health and well-being, which is integrative and universal. But yeah, so just some thoughts and grateful for the conversation.
In the silence, I'll speak. I only feel qualified to talk about the history. So what's happened, perhaps that can act as a guide to illuminate where we go. So in summary, from what I shared with you, you can see that how physiotherapy has changed in its broadest sense. It was everything that was not surgery or pharmacotherapy, but hived off that has become radiology, psychology, further hived off is dietetics. Then you can hive off podiatry, speech and language as well. So it's become narrower and narrower. But what's intriguing is what you guys are doing with this environmental physiotherapy is you're now adding on a whole nother section. And I find that particularly exciting. You know, what this profession can offer humanity in terms of the importance of the environment. And I can't wait to see what happens next.
Thanks, Oka and Glenn, for that answer. And now I really want to also get something from Nicole on this in terms of how you're going to deal with this, you know, definition of whatever field you're studying in the context of your study.
So I actually think what Oka said was highlighting my actual approach to my research is in my position, I do have the ability to kind of allow for improved spaces where my Indigenous colleagues can come in and have almost not a doorway through me in order for their knowledge to be shared, where there might be systemic access issues, especially here in Canada. So I do work with a group here with the hospital system that's in my city, and it's based on Nature for Healing, and it is run by Indigenous members of the hospital community. So they're leading it, and it's all based in Indigenous knowledge. So my work is trying to kind of bring that in the biomedical lens that physical therapy loves and doesn't want to separate itself from, in order to allow for improved space and acceptability, because that really is something that I can tell you now from my couple months in my program isn't something that's ever talked about, is how to actually move away from the very typical isometric strength. We're going to do palpation. There's no thought of how to actually approach things with sensitivity to other ways of knowing. And even when we do talk about things like social context or environmental context, it's never a broader worldview. It's just, what is someone's socioeconomic status? Do they have a social group that they're a part of? So I'm trying to kind of be the middleman to allow for more acceptability, especially within education. Again, I have a Canadian lens, but it's very, very poorly incorporated. And I think it's now becoming a standard that you do have to have Indigenous history knowledge before you do come into a physical therapy program. But historically, that was not the case. So if that kind of cleared my stance between the two paradigm views, but I hope that answered the question.
Excellent. So any other questions for the presenters, or just questions to throw out to everyone who's here today?
Worst case scenario, I always have a question.
Excellent.
And I almost want to, you know, I realize that, you know, for some of our listeners right now in this session, this is early in the night or in the morning and things like that. But I wonder if some of the people here have experience with using nature-based health and therapy approaches in whatever way, and if there is something that, as such, you could maybe share on. I think I'd really love to hear what, you know, people's experiences are with some of this. Hello, Susan. Good to see you.
I could just, because I work in home care, I think in the home health setting, we have some more flexibilities. And for some of our patients, they may be in areas where access to nature is very limited, and safety is a big concern with even venturing outside of the house. So that's especially challenging. But for many of our patients, we're working with them outside on their outdoor mobility, being able to enter and exit the house and able to incorporate walking. You know, frequently patients have wanted to show me their plants. So we walk around outside and they're pointing out their plants and talking about how they hope to be able to be doing more with them, maybe sitting outside with pets or plants or other things. Just some patients have easy access to nature, even when their mobility is quite limited, so we can tap into it. What I was going to ask was sort of the flip side of, well, maybe not the flip side of that, but I was wondering from panelists or anybody else in the group, what kind of facilitators of nature-based therapy? I mean, there's the barrier of, it seems that so many physios are not aware of the benefits of nature-based therapy. Those who are often working in settings where the focus is on meeting accreditors' requirements related to cleanliness and not having any dirt or things of that nature around. So I'm just kind of curious of what other facilitators anybody else is encountering, or suggestions for how systems could be more supportive of nature-based therapy. And thank you all for your presentation.
Oka, do you want to?
Yeah, no, thank you. There's great observations and great question. My offering would be with some of the forums I've been involved with internationally, one of the key themes around the world is a shortage of workforce. And so I think, I'm going to take your question around facilitators and Glenn's presentation around some of the global factors that really shaped the profession. I think one of the ones that we're facing at the moment is a shortage of workforce, and what that means for, our academic educational institutions, but also the reliance on the others. So others who are already working in the community. And I think certainly in New Zealand context, there's a push to bolster primary care. And so that means including, really increasing the workforce of the unregulated workforce. And they are often the ones that are more agile and more mobile within the community and accessing, the parks, the gardens that David talked about, the ocean, the seascape, and can deliver many of our therapy programs in people's home context. So that's one of the facilitators I see at the moment from my perspective, is a sort of a downward push or designation, I guess, of responsibility and responsibility to this workforce that is closer to people's home environments.
Are there any other perspectives or experiences that people would like to share?
Hello, I'm just trying to look for where the hand raises. I can't find it.
That's all right. Go for it.
Okay, my name is Aja. Oh, I look a bit dark. It's 2 something in the morning. So I'm speaking from Ghana, and I'm really excited about this webinar. Really, really excited. I've been looking forward to it for a long time. Because I'm quite new to the whole environmental physio nature-based thing, although it's right in front of us, come to think of it. And listening to Glenn's presentation, I realized it's really a shame that where we came from, and literally our thing is called physical therapy or physiotherapy. We've now become so indoors. In my setting in Ghana, we are very, very much indoors. And I remember the closest I had come to doing nature-based something without thinking it was one time that there was a person who had undergone this surgery after a fracture, and I realized that she was outgrowing what we could do in the gym, so I needed to give her something more challenging. So now whenever she came, we would go out, take a walk, around the hospital, and at that time, I think I was the only one doing it. And sometimes people will question that, oh, why? Like, what's wrong with being inside? Is there something happening inside? I'm like, no, this is intentional. We are doing this on purpose. And that time I didn't even know about this concept. And now I was telling Philip the last time I'm doing my PhD as well now, and in physical activity, people with leg amputation in the context of Ghana. And a happy accident, I'll say, is one time when someone told me about the walkability skill, the news tool, and in there were questions about trees and, do you have the birds in the environment and all that. And at that time, I was like, what is this all about? I don't even understand why I have to ask these questions. And then I went to the physio conference last year, and that was the first time so I walked into the symposium of environmental physio, and I learned about this. I was like, wow. So it's made a big change since then. When I interviewed the people, and I finished, I'll give them tips like come outside. Do you have a garden? And I was using this tool on physical activity. The physical activity skill for people with disabilities, and in there is do you have an outdoor garden? Have you done any lawn work? And almost, in fact, I don't think there's anyone out of about 61 people, not one had done any gardening or had any gardens. And so now learning about this, I now see like there's such a there's a need for something like this. And I also think it's because we overprotect, like David Butler was saying. In this, in my research experience, I got to meet this support group for people with amputation, and I still work with them outside of the research. Like they invite me to give them talks and stuff like that. So last year, there was the first ever games day. We had a games day. So the woman talked whether I could help them with something like this, and had never done something like that. And I was like, wow, I'm a physio, and beyond teaching people with amputation, okay, walk with Zimmer frame, crutches. After they're discharged, that's it. So knowing what to do with people who live in their communities was like, I had to struggle a bit. And so, okay, I realized that they're not as fragile as we think. We did games, yeah. We had like sprinting games, there was a hop race. Yes, someone fell, but it wasn't like there wasn't any injury or what. They were so happy. We had musical chairs, and just by doing that, like I started thinking like more, like, okay, so this year we did it again. We added more games, and I have just come to understand a little bit about this Indigenous, I don't know the full word for it, but I thought that we actually have a lot of Ghanaian traditional games that are almost getting extinct, and I incorporated some of them into this year's games, and the people were just so happy about it. So I'd just like to say that I'm really happy with what everybody here is doing, and yes, we shouldn't be afraid to explore. Yeah, thank you.
Thank you for sharing that experience. It's fantastic. And I think going back to the safety one, which is of course important. So I was similar. When I was a student, I did my rehabilitation placement, and one of my patients, her main concern was being able to get stuff from her letterbox when she went home, and be able to make someone a cup of coffee if they came to visit her. So she was deconditioned, been in hospital for a long period of time, and the previous physio students had her walking up and down the hall, and she could do that okay, but that's going to be very different to her going into her garden or going to her letterbox. And so I'd take her for a walk around the block. And I didn't think of this as nature-based therapy or anything. It was just seemed logical because it was the context that she was going to have to tackle. But thinking back on the conversations we'd have, it'd often be about the plants that we would see along the way or the birds that you'd hear or see. And so it was nature-based physio without it being intentionally so. And it's, in the last few years that I've kind of started reflecting more on what I was doing as a physio and realizing that there was overlap. But I think with the safety, because it's something people raise all the time, I think safety in terms of things like falls or having an infection that might be related back to gardening or something is obviously important. But I think the reason we focus on it is because it's a very discrete event that we can say, yes, that's happened, and this is likely what's led to that. But we kind of forget about what are people missing out on when they don't have these exposures. And so now that we've got this understanding around the benefits of nature, we can use that to educate the patients and their families and administrators and other health professionals to kind of go, here are the things that could happen. It's just that those things tend to happen over time. So someone's isolation or mental health or reduction in function or reduced ability to go into their own garden is something we can't easily measure and attribute to the fact that we haven't rehabilitated them or worked with them on safety and confidence in those environments. So I think it's trying to reframe that thinking and acknowledging that there's this other layer of safety or hazard type outcomes that we need to be aware of, even though they're not those discrete, reportable type outcomes. So I think that's why events like this are so important, and sharing the evidence, but also people's experiences and perspectives is really key, so that we can communicate with patients and clients and others about what people are actually losing as a result of us not considering these exposures in our therapies. But Philip?
Yeah. So, okay, let me see how I can formulate this. So, so actually across, again, all of the presentations that we've had here today, and also now these kind of conversations about, people mentioning kind of nature-based health and therapy in community settings and community contexts, and the role of communities in nature-based health and therapy. My question, and I'm not sure if this is like the super right formulation, but I feel like there is a question around who owns nature-based health and therapy, or who has the right to prescribe nature-based health and therapy, or maybe who just has the ability to do so. And it seems to me from all your presentation that it's nature-based health and therapies, as you all said, have been used in all sorts of different contexts. Indigenous people have used it for thousands of years potentially, and then physiotherapists have kind of made a profession of some of it, but then it's also used in community settings, and clearly loads of people are doing it that are running community gardens but are not physiotherapists, and people are just going into the park for a walk, or into the garden for a walk, or to their letterbox for a walk, and doing nature-based health and therapy. So my question, I guess, is it a problem, or is it some kind of opportunity or advantage that it's so difficult to lay claim to nature-based health and therapy, that everyone can do and engage in it and administer it and prescribe and so forth? Is that a problem, or is that a strength or something like that? Yeah. And anyone is welcome. Yeah. Yeah.
Can I comment on that? Because I just see opportunity as optimist in me. No one wants to know about it. Medicine isn't capable of doing it. No one else is doing it. And the opportunity for physiotherapists to get involved in local government, in cities, in prescribing environments that offer everything you've described, it's exciting. And the history of physiotherapy is full of examples where poorly behaved women have challenged the status quo and changed. And I suspect the world is just waiting for us.
Thanks, Glenn. Go, okay.
Thanks, Philip. I think I guess I go back to it depends on the paradigm that we're viewing through. From Indigenous paradigm, it's by birthright that you have a right. By the fact that you're born, you have a right to access nature. But with that comes a responsibility in terms of what I've mentioned around nurturing and protecting the relational space with nature and all that nature gives life to. I think my personal view is I have an issue with the sense of this prescribing nature-based therapy. That for me, that comes from a different worldview that looks to seek control over something, package it, and then deliver it to someone of need. And that there's a whole inherent sense of power imbalances within that, a potential arrogance as to owning something that is just kind of become by was here before us and will be here after us. So that sort of sense. So, and it might be the languaging around it that I would need to reflect upon to feel more comfortable about yeah, how we as therapists, contemporary physiotherapists, integrate nature in our therapy programs, but also not impose perspectives or discourses of ownership and extraction and utilizing this to get that types of things, because that's in contrast with the indigenous cultural or principle-based sentiment of guardianship and protection.
Thanks,
Just
Oka.
I think that was very well said, Oka. I was just thinking before you started to speak, and I think there's a presenter tomorrow that's talking about the PRX program that we have here in Canada, which is prescribing nature. It's started by physicians, as far as I understand, but they've included all regulated health professions as people can sign up and prescribe nature to their clients or patients. So actually, I'm not sure which time that presentation is tomorrow. If it's in the middle of the night, I might not be joining, but it would be nice to ask the presenter, like, how much has that program considered, not even considered is probably not the right word here, but is working with Indigenous populations and in terms of how they're running the program. I don't know if anyone knows more about that program, and I know it's been, yeah, maybe from speaking to the presenter, but it was just thoughts that were running through my head as Oka was speaking, and knowing that presentation is coming tomorrow, and not to put it on the presenter themselves, but it just was wondering.
I can see if I can relay the question. I'll be awake in that session. Yeah, I can see if I can relay the question, but I know that there are some active communication and collaborations going on also in the context of PRX. Yeah. Or parks. Yeah.
All right. So any final questions or comments before we finish up? Question. So does that mean that physio education needs to change? Good question. Yeah, so lots of people nodding. Yeah, so I guess, my perspective on it is framing it as part of physio, and I'll talk more about that in the next session when I'm presenting. And yeah, appreciating that it's part of what we have been doing for a long time, as Glenn's pointed out and as Oka's pointed out, and giving people the strategies and tools to do that, and obviously trying to bring in the local perspectives, particularly of the Indigenous populations will be key in that as well. Any other thoughts from people around Kirsten's question?
I have a thought in relation to Philip's question. And Philip, as you asked it, it caused me to reflect to one of our colleagues, David Nichols, who you may have met before as part of your own development. And his talk about the enclosure of the physical therapies, of carving it off as a scope of practice that we own, the sense of ownership that Oka drew upon. And it's making me think about how those systems that have been created about prescription, scope of practice, expertise are tools that are very active these days, and how deploying them can actually be a beneficial thing. Possibly part of incremental stages that reduce the biomedicality of the type of work that we do, but also that challenging them can lead us to a more radical and exciting place. And the interesting thing that is firing for me right now is how we might engage in both of them. It seems to me that it doesn't make sense to completely push away those tools that are available to us. But getting involved in the other stuff of seeing things differently is really exciting. And I hope that we are able to engage in both of those things simultaneously.
Yeah, excellent thoughts. Philip, you were going to say something? No?
I was going to say
right.
that Sean just had a lovely closing word there. So thanks, Sean.
Yeah, fantastic. All right, so I'm just going to share my screen briefly. All right, so this is obviously the first 4 presentations as we've discussed. So we've got the next presentations at 9:30 a.m., 6:30 p.m. and 10:30 p.m. and this is Central European time. So hopefully everyone can attend at least one more, and obviously there's enthusiastic people already on the call who have got up in the middle of the night, so thank you for doing so. I think most people are probably members of the association, but if you're not, it's free. It's open to non-physios as well. So anyone who's interested in this space, we have quite a few members who aren't physios, which is great. So the website is there. And then I just want to point out that we've got a survey open at the moment. And this is 5 years or so into the Environmental Physio Association. And we're just wanting to get perspectives from people or feedback from people in terms of what we're doing, what's working well, what we can offer in the future, and things like communication methods. So the survey is open, the link is there, and the QR code is there as well on your screen. So it'd be great to get more people participating in that survey so that we can make sure that we're tailoring what we're doing to the needs of the members. So I'd like to just finish up by thanking all of the speakers and thanking everyone for attending today. As I said before, it's fantastic to have those different perspectives presented all in one session, and we look forward to seeing you at the remaining sessions. So thank you.